Hi everyone, I'm John from HTN and welcome to this webinar today titled Building Safer Care, Embedding Clinical Safety into Digital Pathways. Today's session is about how digital pathways can support safety and help to ease the workload for frontline teams. You will hear from clinical safety officers and digital leaders on what it takes to embed safety into everyday practice, and we'll go into how the right tools and digital can support consistent and reliable care. So I'm really pleased to welcome a panel joining us today. We welcome Karina Hulks, the Associate CNIO at Health Systems Support Limited, Victoria Mustafa, the Regional Quality Safety and Digital Lead for the London region at NHS England, Ruth North, the Clinical Safety Officer at the Leicestershire Partnership NHS Trust, and Pete Hansel, the CEO and co-founder of Isla Health. So welcome to the panel and thank you for joining us today. I have a couple of housekeeping things to cover before we start. If you in the audience have any questions that you'd like to ask, please do so in the chat. So I'm really keen to hear from you and any questions that you might have. And we have a planned Q&A towards the end of the session as well. Finally, this session will be recorded and there will be a write-up by the HTN team, so you can read or watch it back at a later date and share it with your colleagues too. So the agenda for the session, we will hear from our panel in terms of what building safe care means in practice and how digital can support it. And then we'll go through our panelists and then we'll go into a Q&A. So that's the chance for you to ask any questions, to dig a bit deeper with our panelists. So I'd like to start actually with a question for you in the audience. So we have a poll. And the question is, how does clinical safety influence your willingness to implement digital tools? We have a Slido. So if you go to slido.com and type in the PIN code that you can see on the screen, you'll get to an area where you can type a response to the question. Or if you use your smartphone, scan the QR code and that'll take you to a place to answer the question directly. And those responses will come through directly to this PowerPoint slide here, so we can see your views. So yeah, very keen to hear from you to kick us off. So great, we've got a couple of responses. It's imperative, massively, yeah, completely agree. It's vital, leads to a lot of resistance, not reliably trusted. It's an essential part of the EPR work, very important, significant. Okay, so it's a really nice way to start the webinar, highlighting the significance of clinical safety in digital pathways. So thank you for taking the time to respond to the poll. So let's go into the session. If I could ask our panel to introduce yourself, your role, your remit in organisation, and then a question to you. Could you explain what building safe care means to you in practice and how digital can support it? So Karina, welcome to the webinar. Could I start with you, please, for that one?
Hi, sorry, my computer's playing up. I'm not having much luck today. So I'm Karina Hulks. I've been a CNIO in NHS Trusts for the last 7 years, and in one of those organisations, I was always also the clinical safety officer. So obviously, clinical safety plays a huge part within my role, and I've been involved in implementing various EPRs and various digital tools where, you know, we've obviously looked at the aspects of clinical safety and how it's going to impact on end users when we're implementing tools. In terms of working with tools, so I first started working with Isla when we implemented in one organisation, but I'm not going to talk so much about from a CSO perspective, because obviously Ruth is here and she'll cover those aspects. But I wanted to talk about a use case where obviously when you're implementing digital tools, you need to consider clinical safety, but I also wanted to look at it from the other end. So introducing a digital tool to improve clinical safety. So I worked in an organisation that didn't have a robust process for capturing clinical photography. And what happened was there were some digital cameras around the organisation. Different services use them in different ways. Other people use their personal devices to capture images. They shared them on WhatsApp. So as you can imagine, there are huge risks around that. So both taking them and storing them on personal devices, but also sharing them in a non-encrypted format. And the other issue was where they were captured correctly, they were uploaded to shared drives. So not everybody had access to them. So that impacted on patient care because the images weren't available at the point of delivery. So we looked to implement a digital solution to resolve these problems that were happening in practice. So in terms of implementing a clinical photography solution, obviously we had to work with IT, but we also had to work with information governance in terms of what information was being shared, how it was being shared, if the data was secure. And I think what we did was we improved the patient safety and the patient experience significantly by utilising a tool that could capture the data, but also share it in an encrypted format and also integrate with EPR, which meant that clinicians only had to go to one place to access images in a safe way, which meant that they were better able to use those images in clinical decision making. And I think it improved the staff experience, but it also improved the patient experience. And I think that the patients, therefore, they were able to have more confidence in clinical staff because the images were available when they needed to be and where they needed to be. The staff appreciated the introduction of the tool because they were able to see the benefits. They were able to appreciate that they were now capturing images in a safe way. They were sharing them in a safe way, and they were easily accessible to all who needed to see them. And I think that also improved the patient outcomes because it meant that there were no delays in patient care. So it meant that those decisions were made in a more timely fashion. I'm rubbish at timekeeping, John. So if I've not filled my 5 minutes, I can waffle on.
That's great. Thank you, Karina. We have some time for a Q&A. So if anyone in the audience would like to ask Karina a question about that project, type them into the chat and we can go through that shortly. So next up is Victoria. So Victoria, welcome to the webinar. If you could provide a wider introduction for me, please, and then go into and help explain what building safer care means to you in practice and how digital can support it.
Thanks, John, and good afternoon all. So I'm Victoria Mustafa, that is my digital me on the screen. I'm currently the Regional Maternity Quality and Safety and Digital Lead, as John mentioned earlier, at NHS England. So my digital career started as a digital midwife. During that time, I was the first and only clinical safety officer within the entire trust. So as you can see, we've come quite far since then. I then went on to be the digital lead for maternity in the ICB, and now I'm in my current regional role. So with both my quality safety and digital hat on, I work across London supporting trusts to improve safety and maternity care, often through digital innovation. Every trust I work with faces different pressures, as we all know, whether it's staffing, capacity, or system fragmentation. The goal is always the same: safer care for patients. So for me, building safer care means embedding safety into everyday practice, not just policies, and digital can support that by enabling earlier intervention, clearer communication, and more joined up care. So my slides reflect how we move from siloed systems to collaborative patient-centered safety, where digital is the enabler, not just the endpoint. So for this slide, having introduced my role and the pressures trusts face, I want to focus now on what embedding clinical safety really looks like in practice. So it starts with recognising that safety isn't owned by one team. And this is what I've learned through my journey from being just in a digital team to now a more collaborative digital and clinical safety team. So it's a shared responsibility. Patient safety, digital clinical safety and governance must work together and not in isolation. When we bring these domains together, we move beyond compliance. We create digital tools that are co-designed with safety in mind, that reflect frontline realities and that genuinely support safer care. This kind of collaboration doesn't just improve systems, it improves outcomes. It's how we make digital meaningful and how we ensure it strengthens and not complicates clinical decision making. Next slide, please, John. So finally, for me, building safer care means putting patients at the centre of everything we do and using digital not as a solution in itself, but as an enabler of better care. Digital pathways can support continuity, transparency, and timely interventions, especially in maternity and urgent care settings. They help us spot deterioration earlier, escalate faster, and make safer decisions in real time. It's not just about the tech, it's about the culture. When digital is embedded into governance, safety becomes proactive, not something we audit after the fact. And crucially, collaboration is key. So I'm seeing this more in my current role, that patient safety teams and digital teams must work together to create joined up care. That's how we move from isolated systems to integrated safety. So the opportunity ahead is clear: to use digital to strengthen and not replace clinical judgment, and to build care models that are safer, more responsive, and truly patient-centred. Thanks all.
Thank you, Victoria. Some great points there and really nice slides. So thank you for that. Ruth, could I come to you next, please, in terms of a wider introduction and explain what building safe care means to you in practice and how digital can support it?
Certainly. Good morning, everyone, or afternoon now. My name's Ruth North. I'm the Clinical Safety Officer, one of the Clinical Safety Officers in Leicestershire Partnership NHS Trust. We're a community trust, and we are working with Isla across our trust, but predominantly it's quite well embedded now over the last year in our community health systems and our community nursing areas. So we've been using it a lot for wound management and documenting that sort of thing. So using the photography, etc., and embedding that into our electronic health record. So for me, clinical safety starts with, what does the product do? Is it something that we can use? Is it going to enhance what we do already? Is it going to make life simpler for our clinicians? Is it going to give us a better system than we currently have? So it's those sorts of questions to start with. Then it's understanding the platform that we're looking at, and will it deliver what we want it to? How do we want to use it? And really testing that before we implement it. So getting our clinicians involved in some of the prototype type work and understanding what they want to be able to see and do with it. So that's our sort of primary point of care when we're looking at any digital system or any platform that we're going to look either to link into our own electronic health record, or that will sit alongside it and we can use APIs, etc., to then embed information from another platform into it. So some of it depends on how it translates across as well. Our initial point of call is obviously to do our software analysis and see what risks it poses for our system or overall, where those risks are, if anything can be mitigated, etc., how it integrates generally with any of our systems, if it's loaded on our laptops, is there any crossover there, that sort of thing. So we do a lot of background checking to start with before it even gets to that clinical point. So it's about how it works with everything else that we've got. And then I think we rely quite heavily on the manufacturer giving us their safety case file with their hazard reviews and hazard logs, and looking at how those hazards that they've already identified impact on our delivery of care and what we can do to mitigate those. And then any additional points that we think of that will need to be mitigated for our use of this product. So that's sort of where we are at the moment. And I know that our teams have been working really closely with Isla, and there are already elements of development in place for areas that have been identified where we'd like a bit more mitigation availability, just to try and improve that clinical safety for our clinicians and our patients. So hopefully that's everything.
Fantastic. Thank you for that, Ruth. And sure, we'll have some questions to go into that project when we go into the Q&A. But next up is Pete. Pete, could you share an introduction about yourself, your role remit, Isla Health, and as well answer the question of what digital safety means to you and how digital can help?
Yeah, thanks, John. So yes, good afternoon, everybody. Pete Hansel, CEO and co-founder of Isla. So in my role, I suppose I'm very, very focused on how we can use and build digital technology to help the health system at a very kind of global scale. And a massive part of that for us is the impact on patient safety and clinical safety. So I think I kind of wanted to zoom out a bit from the way that we often think about clinical safety and really get back to sort of safe care as almost the sort of foundational thing that we need to get right within the health system. And I think that's, we all sort of know that, but it's almost worth reminding ourselves. So this first do no harm concept, which is kind of a guiding principle of medical ethics and a core tenet still of the NHS, I think is almost our jumping off point for this. And Victoria referenced this nicely earlier as clinical safety is a frontline priority. And so I think that's the way that we try to remind ourselves to think about this. So what does sort of safe care mean to us at Isla? We think about it, I suppose, through two slightly different lenses, and maybe in some ways they come back together to be the same thing. But from a patient lens, you can pull out across the health system many examples of events that have had negative outcomes for patients that we can learn from, and that in an ideal world we can prevent from ever happening again. And in the root cause analysis of a lot of those events, often there's a kind of communication or information gap component to what's caused that problem. And so digital and building established kind of standardized digital pathways, I think, is a very powerful way to begin to close those information and communication gaps. So that's kind of from a patient perspective. And then if we look at this also from a NHS system level, I think that in some ways the biggest clinical safety risk that we have in the NHS is that we have these really long waiting lists. And so patients can often be referred into the system and then deteriorating on a waiting list for months or years. And without the right systems and processes in place to keep track of those symptoms and the sort of relative urgency of being able to treat those patients, we have a real problem and a real risk that patients are degrading without being picked up. So I suppose that's the very zoomed out way through which we like to think about clinical safety in its broadest context. It's both in the detail and in the micro of what can we do day to day to make sure that we're implementing new safe systems, but also what can we do holistically to make sure that we're actually advancing the health system so that we're delivering safe care for patients at a very global level.
Fantastic. Thank you, Pete. And let's go into a Q&A now. So this is your opportunity in the audience to ask our panel any questions. If there's anything you'd like to ask, type those questions into the chat. and we'll go from there. So the first question, Karina, could I come to you, please, for the first question? When you look at safety in digital pathways, what measures or indicators give you confidence that they are delivering real improvements for patients and staff?
That's a tricky question, John. Yeah, I mean, I think obviously, as I've already stated, when you're implementing a digital tool, I think you need to be really clear about what is the problem that you're trying to solve. Because I think often we find, and I've seen it in, you know, a few organisations that I've worked in, that there are a multitude of tools out there, and often there is crossover about what they do. So I think firstly, be clear about what the problem is you're trying to solve, and then really understand what your baseline is. Because as I alluded to in the use case, if you've already got a situation where you've got high levels of risk, what you need to think about is, by implementing this tool, yes, we need to fully examine what actual or potential hazards the tool may bring by introducing it into this organisation and using it in this way. So I think, you know, having that clinical hazard workshop with people that are going to be using the tool in that specified way is really important for you to understand the actual hazards or potential hazards. And then obviously thinking about the mitigation. What mitigation can you put into place, and what is the residual risk level that you're left with? And is that residual risk level a much better situation than before you implemented the tool? Have you solved a lot of the risks that you were aiming to solve? So I think it's really important that you get that baseline, understand what your current risk level is, fully understand what additional clinical hazards this tool may bring, make sure that you've got that mitigation in place, and then it's about monitoring. Because I think sometimes people do a clinical hazard log, they put these mitigations into place, and then perhaps sometimes they don't go back and review, is that measure actually bringing the risk level down, or do we need to modify it? So I think it's important to have that monitoring in place to make sure that what you're doing isn't creating any further hazard, but it's an improvement.
Fantastic. Great answer. Thank you for that, Karina. Victoria, could I come to you next in terms of your perspective, please? And where are you seeing digital pathways making the biggest contribution to clinical safety for frontline teams?
Yeah, so for me, I think the digital pathways are making the biggest impact in regards to clinical safety by improving access to real-time data. We've still got a long way to go, but as someone mentioned earlier, standardising care is super important, enhancing communication also. In maternity services, tools like digital early warning systems, very important. Electronic referrals, get those referrals much quicker. We've recently done in utero transfer platforms to help frontline teams respond faster in, you know, time critical situations. And also when co-design with clinicians, it really helps get it embedded into the daily workflows. These systems reduce variation, support timely escalation, and ultimately improve outcomes for women and babies. And this goes across, I'm also a qualified nurse, this goes across the whole patch, not just for maternity.
Thank you, Victoria. And Ruth, could I come to you next, please, as a perspective from a clinical safety officer? What's the most important principle when embedding safety into a digital pathway?
Does it work? Does it work, and does it do what you want it to do? Does it work for your clinicians? Is it saving them time, or is it increasing their workload? That's some of the biggest stuff I think we have to consider. There's always an element of training required and staff needing to understand what it is they need to do differently. But I think once that initial training's been embedded, you know, what's your feedback like from your staff? Is it working well? What areas are they struggling with, and seeing what you can do to improve that for them. It's one of the things that I know we have, because we've got some really rural areas with very poor Wi-Fi signals and just general telephone signals for anyone. And so we've got an offline element now. So we can still capture our pictures, and as soon as staff come back into an area where they have got a signal, the pictures will upload. It's not held on the phone, so we've got that safety still there, but we have got that ability to work sort of even when we're in poor areas of signal. And like I say, we've got some really poor areas of signal in Leicestershire and Rutland. Yeah, very hilly, very little masts anywhere and things. So, you know, that impacts on all of our community nursing areas. And it's a constant issue that we're sort of fighting with. We're also based in very old buildings sometimes, and the signals again are quite poor. So all of that sort of thing has to be taken into consideration. I think from the clinical safety side of things as well, it's about that ease of use. So if we're asking our patients to use it, and particularly perhaps more of our elderly patients or our older patients who are less comfortable with some elements of technology, we need it to be super easy for them to be able to send information back into us. And Isla is very easy to use. The patient gets an easy link, they just click on it, they take their picture, they submit it. It's super easy and simple for them, and they can review it. So it's that ease of use for both our patients and our staff that is really key. And then the ability to develop as we go along as well, you know, so that we can continue improving what we can provide.
Fantastic. Thank you, Ruth. And Pete, could I come to you with a very similar question, but from your perspective and from Isla's perspective? How do you ensure clinical safety is designed into the platform?
Yeah, thanks, John. So yeah, with Isla, I suppose it's probably helpful just to give people a sense of what we do. So we've built what we call the digital pathway platform, and the aim there is to work very closely with clinical teams to standardize the way that we would expect a patient to be looked after and the decision points along a patient's care journey, kind of end to end, from primary care right through secondary care and hopefully out into kind of out of hospital monitoring. And the value of that is that we can begin to iron out a lot of the delays that happen in the health system, because often what we're waiting for is an information gap to be filled. And very often we can fill that without having to bring a patient into hospital by collecting that information from family members, from school teachers, from patients themselves, from querying data that actually already existed in the EPR and structuring that alongside other pieces of information that are flowing in kind of as the patient moves down their digital pathway. So that's the product that we're building. And the sort of the key part of that, I think, is the clinical design of these pathways. So Isla sort of quite intentionally doesn't have clinicians in the team because we don't really want to introduce that kind of possibility of having an internal bias towards particular the way something should be designed clinically. And instead, we work very, very closely with every trust that we deploy with, and also very closely now with the GERFT team at NHS England, who have been sort of designing standardized best practice for the last decade or so. So that's what we're aiming to do, is build towards very standardized, deployable nationally digital pathways, whereby every patient who comes into the health system is at all times kind of flowing in an optimal way through to the next treatment or intervention that is right for that particular person. And maybe it's useful just to kind of bring it to life with a couple of examples of that. So one of the pieces of work that we're now doing with London North West, which is where the project that Karina originally kicked off with us, is to support them in implementing Martha's Rule. So I'm sure people are familiar, but Martha's Rule gives families and patients the right to request a second opinion if they feel that their sort of primary opinion from the clinician looking after them isn't satisfactory. And so that's a really nice example of how we can improve safety for patients with actually quite a simple intervention. So we've, over the last 6 months, I think we've had 2,500 submissions through Isla from patients and family members who are monitoring daily a patient's symptoms. And then the platform helps to sort of triage that data and highlight for clinical teams where somebody's symptom is trending strongly in one direction. And so that's really helped the team to sort of have a much more data-driven conversation with patients on the ward, and to then sort of guide how we implement Martha's rule and when it's appropriate to seek a second opinion. So that's been done by 3 wards now in London North West, and we're rolling out to 45 further wards kind of over the next few months. So that's really positive. And then another nice example, kind of totally the other end of this spectrum. So we're doing a piece of work which is led by the GERFT team to try to move towards a much more standardized way of monitoring men who've had prostate cancer, or perhaps, and this is for men who've either had prostate cancer or still have prostate cancer, and we're in a kind of active surveillance period. So very, very quick context that I'm sure there's a lot of clinicians on the course we probably don't need, but prostate cancer is the most common form of cancer for men. It makes up around 26% of cancer in men, and the prevalence rate is growing very quickly. So forecasts grow 10 to 15% in prevalence over the next 5 years. So the safety net that we should provide there is quite well defined. So for people who are on an active surveillance pathway, we should be taking a blood test and checking the PSA level every 3 months, and based on that set of inputs, and also just kind of as time elapses, every 12 months we should be having an MRI or a physical examination. So it's a very well-defined pathway, but it's done very inconsistently across the country. So that's a great example of where the kind of safe pathway is well understood, and actually it's much more of a systems challenge, where if we had something that integrated tightly into EPRs and was deployable nationally, then we could very quickly kind of get everyone to the same standard of care and safety netting there. So I'll kind of leave it there, but hopefully that's just 2 nice examples of, I suppose, actual implementations of digital pathways and how that can impact safety.
Excellent. Thank you for that, Pete. The next question, Ruth, can I come to you from a CSO perspective? It's how do you ensure the tool is GDPR compliant, specifically if the tool is from a company outside the UK?
Well, for us in our trust, we look at where if anything is being stored externally or routed through anything externally, where is that server, etc., being held? Is it in the UK or is it further afield in Europe or America? And if it's not compliant with our standards, then it's not something that's going to be used in our area. So that's how we conform to GDPR. Is we look within our software approval elements and our devices requirements at what the manufacturer is giving us. If they're not very clear, we'll ask for more information, and that's part of that scrutiny. When you're looking at any product, you're looking for, what patient identifiable information is going to be required in that particular platform. Where's it being held? Does it need to be on there, or are there other ways we can manage that? But generally, we as a trust don't tend to use anything that's got anything held in America. We don't feel their standards are very safe. Europe, we're not overly keen on either. We try and keep everything in the UK as much as possible. So yeah, it's just going through the appropriate screening with your cybersecurity teams, with your IT teams, doing all the testing. And if we're not satisfied with the sort of answers and information we're getting from a company, that, we keep asking until we are. That's the key.
Thank you, Ruth. Pete, is there anything that you would like to add from your perspective to that question?
I think from our perspective, we probably went on quite a sort of steep learning curve when we started Isla, so 6 years ago now. I actually think there's quite a lot said by startups about how difficult it is to sort of start to work with the NHS. And I think that's both true, but also the requirements are generally very, very clear. So from our perspective, it doesn't, there's a high barrier to make sure that you comply with in terms of the way that you're storing and handling sensitive data and all of the processes that need to run in the business to make sure that kind of we're minimizing risk. But I don't really think it's fair that startups sort of sometimes claim that it's not clear, because I think actually it is quite clear, and it just is quite a high barrier to hit before you start to handle sensitive patient data, which is sort of the right way it should be, really. I suppose the counter to that is there are, from our perspective, sometimes very surprising differences in local trusts and interpretations of things. So it'd be great to be moving as much as possible towards a once for the NHS approach there. So yeah, we see it both ways, but I think as a company, it's very important to be not be seeing clinical safety as a blocker or as tick boxes, and instead be seeing that as just a core responsibility of running a company which is going to help support health systems, and sort of jumping onto that and getting that embedded in the culture of the business very early is a very important thing to do.
Thank you, Pete. The next question, Karina, can I come to you for this one? This is a nice question. Any tips on adoption to make sure tools are used as envisaged?
Thank you. Yeah, I mean, I think the biggest sort of barrier to adoption is if the tool doesn't have good usability. If the tool's really complicated to use and it takes hours and hours of training, people are going to be less likely to want to use it. So I think good usability is the first thing. Then obviously providing the right level of training. So you don't want, you don't want to overload people with training, but you want to get that balance right in terms of people having enough training to be able to go off and try it, but also having resources available to supplement that training. So if you have a sort of a relatively short training, but people have somewhere else to go to find out information if either it wasn't covered in the training or they've forgotten. And I think the other aspect to that as well is having at the elbow support. And this is something that I've always made sure that we had. So people have their training, you make sure people feel comfortable in using the digital tool, but then there is some after support. So it's not just a once only training, off you go, and we're going to leave you to it. It's about having that consistent support. People that can go around. I'm used to having a fairly good sized team. At London Northwest, we recently employed some digital clinical educators, and their role is to go around all of the clinical areas, check what people are doing, check do they need any more support. So I think, and it's important to listen to feedback as well. If people are giving you feedback on, oh, this is difficult, that's difficult, or, the lack of adoption may be that they haven't got the right hardware in the area. So it's looking at all of the sort of peripheral factors as well, to see how you can make it easier for people to use and to successfully adopt.
Excellent. Thank you for that, Karina. And Victoria, could I come to you in terms of any tips for adoption that you would like to add? And as well, how do you do digital skills testing for the people that are going to be using these tools?
I think Karina's covered a lot of it, and being visible. I'm a really visual person, so I need to see something to have it, stay in my mind. So when I was being a digital midwife, every Friday I'd go around and be on the shop floor, and it's amazing what you pick up that people have just never mentioned. They can't open something, a simple form, for example, and then once you've shown them once, it's transformed their life. It's amazing. I used to love my Fridays. So digital skills testing is again, it's being visual and seeing what the issues are on the shop floor, being there and gaining that experience with them, alongside them. Because there are some people are very digital mature, some trust the digital mature, some are not. Again, as Karina said, it's all about the technology. Do we have the right systems in place? And if we don't, we need to flag that, because they can't do their jobs without having the right digital systems and the right digital skills. And we do need to pick that up, not at the beginning of the implementation. I'd say it's completely throughout. So it's ongoing. Shouldn't be at the beginning, shouldn't be at the end. It should be ongoing.
Super. Thank you, Victoria. Right, next question. Ruth, can I come to you for this one? This is a great one. How can we balance innovation and speed in digital transformation with the rigor of clinical safety and ensuring pathways remain safe, evidence-based, and trusted by patients and clinicians?
I think the key is it can take time. It's not always quick, and we try and involve our service users in our development of pathways, so that they are a key part of our development of any services that we're trying to implement new technology into. We want to know what they think about it, how they feel about the look of it. Do they find it easy to use? Do they find it easy to feed back on? That sort of thing. So we try and make sure we have got service users in our development of any technology or any platforms or pathways. From the clinical side of things, then we will always be trying to work a lot with that clinical team, and we're always wanting the team to feed back on, this is where we are now. What do you think to this? What else do we need to consider? Have we missed anything? Is there something in there that's not needed? So we try and streamline it. So there's a lot of preparation work, a lot of initial toing and froing to get the product right before we implement it. And it can take time. And obviously the clinical pathways, staying safe is a huge part of that. So all ours go through our normal governance routes. They will go through our IT routes. It can go up to exec board and things. So it just depends, what type of thing we're implementing as to where it goes within our trust. But it goes through a multitude of groups to get that sign off, to make sure it is something that we are happy with across the board.
Fantastic. Thank you, Ruth. And Karina, to lead on from that and those different groups, nursing, IT, governance, how do you work across those groups to create a shared understanding of safety requirements? If you could give us an example, please.
Yeah, I think it's really important that you do collaborate with the right people at the start of the project, and thinking about implementing ILO at London North West. We actually did it really quickly, and I think it's because we had the right people in the room to agree on those items. So we had a bit of a burning platform, and we had to do something. We implemented an EPR, and we removed the ability for people to easily upload images into a digital platform. So we needed to do something quite quickly. So we got agreement to trial Isla fairly quickly. And like I say, we worked with the information governance lead, we worked with the cyber lead, we made sure that we had all of the documentation from ILO in terms of, being able to write our own clinical safety case report, but also making sure that ILO was compliant with all the guidance, as we've already said, in terms of the data storage and sharing. So I think, it is about making sure that you involve the right people early on, and also, the people that are going to be using the tool. I think that's really important. It's really difficult to get end users to come to clinical hazard workshops. Everybody's really busy, but I think it's really important that they're involved in discussing, what those potential and natural hazards might be, because they're going to be the people using the digital tool. So I think it's important that you make sure that you are evaluating the tool given the way that you want to use it. So I do think good communication is important, and involving everybody early on, making sure that you've got those key stakeholders involved in those project meetings, so that then you can safely but quickly progress through to implementation. I think that those are the sort of key things for me.
Great points. Thank you, Karina. And Victoria, could I come to you from a regional perspective? How do you work with trusts and clinical leaders to ensure that compliance is embedded in everyday practice?
Yeah, so at regional level, we work with trusts and clinical leaders by focusing on learning, not just assurance. We embed safety into everyday practice to support MDT reviews, sharing insights across different systems. We co-develop tools. Recently, we've just developed the patient safety review framework. Lots of you might have heard of PSERF, which is the patient safety review framework. And we saw that everyone was doing something differently. So we've come up with a system that will help them, like Pete said earlier, do once. We've got a terminology of do once for London, and it's not enforced, it's not mandatory, it's just there if they need it. It's about creating a culture where safety is seen as part of good care and not just a checklist. It's really important. And where frontline voices shape improvement, as Karina has just said, it's super important.
Fantastic. Thank you, Victoria. And Pete, from your perspective, please, what have you learned working with NHS partners in making safety and efficiency go hand in hand into projects?
I think, as Karina just said, engaging very early is certainly absolutely key. And I think that trying to move as far away as possible from this kind of idea of clinical safety as a blocker or a hurdle, which it was raised actually in the slide right at the start. I think there is often a perception of that, and so flipping that around and thinking about clinical safety workshops as actually a really valuable input into the way that we should think about deploying a tool is very helpful. And then it gets away from this kind of tendency to leave it to the last minute or to do the minimum in terms of documentation to try and get things sort of signed off and ticked off, and it instead a much more valuable part of a deployment plan. So that's probably the sort of key way that I think both suppliers and trusts need to think about clinical safety and avoid the temptation to see it as, a paperwork exercise, because the value isn't really the paperwork, it's the thinking that has gone into building up and identifying the risks that might be very local risks, and then how we can work to solve them through a program.
Excellent. Thank you, Pete. The next question, Ruth, can I come to you first, and then Pete for the same question, please? So how does Isla make sure it's not creating even more data silos, is the question. Ruth, from your perspective, what's your answer to that question?
I mean, obviously Isla will have its own data elements, but a lot of the data comes back into our electronic health record, and that's where it's held. There are a couple of gaps on some of the pathways that we have currently, but they are being developed as we speak to try and mitigate some of those issues. So hopefully as much of data collected is going to be stored in our electronic health record, so that should minimise what needs to be elsewhere, etc. I think some of it depends on what systems you're using as your electronic health record. So I know that our trust is using System 1, and for us, we do not have the capacity to store video or audio because it's a high memory value. So at the moment, that's something that I think, obviously will be something that gets discussed maybe more nationally with our platform for our electronic health record around what happens with that as we go into more digital formats. It's about having everything stored in one place, but certainly all our photos, etc., are coming into our electronic health record and they're stored within the patient record. So it's not lots of separate data pockets being accessed on different platforms to give the clinician an overall view. It's all within the electronic health record as much as possible.
Thank you, Ruth. And Pete, is there anything that you'd like to add to that question?
I think it's a very good question. So I suppose the first thing is to identify whether actually those data silos already exist and we just don't have visibility of them. So if you go to most community trusts around the country, there'll be pockets of clinicians who don't have any other option other than to capture video or capture sound recordings or photos, let's say, just onto their phone. And so these data silos often exist and might be very invisible. So I suppose that's the first step, is even in a world where Isla was not able to connect into an EPR, the first question to me would be, well, are we a step better than data being stored on hundreds of devices around the county? And my answer to that would often be yes. And then I think, just building on Ruth's point, so that the key is and the ambition should be to try and get as much of this data into one place as possible. And I think there's quite an important distinction there. So having visibility and a lack of data silos doesn't necessarily mean that all of the data needs to be stored on the same server. It means that we need to create for users the ability to see all of that data in context at the same time. And so that System 1 example is a great one. Most of the video and audio data for Trust like LT will be sitting now in Isla. We can connect that into the EPR so that you can hyperlink out from that record and stay in context. You don't need to log in again to clinician, and you can see the relevant data. And so there's that in many ways kind of avoids the data silo. And then it's a continuous challenge of how can we make that more and more seamless, and that varies a lot by EPR. So even if our kind of data outputs are fairly standardized from an Isla perspective, and we can present APIs that are accessible from many from you'll see big differences between how that looks for, let's say, a Cerner trust, where Isla's fully embedded into Cerner in an iframe, and so it's just it looks like part of Cerner to an end user, versus something like System 1 or EMIS, where we're less mature with sort of how we can surface that data into the EPR. So yeah, I think it's both the recognition of the full scale of the problem before we start, and not throwing the baby out with the bathwater. If there's a problem we can solve to get from data on local devices, unencrypted, unsecure, across hundreds and hundreds of silos, and get that into one thing, then that's a good first step. And then what can we do to get that one thing presented in context for clinicians?
Excellent. Thank you, Pete. And I think that's answered two questions in one, which is great. So James, I think we've answered your question there. Let me know if we haven't. Victoria, could I come to you, please? Looking ahead, what do you see is the most important, most immediate opportunity in the next 12 months to strengthen safety with digital?
Yeah, for me, I'm quite excited. It could go either way, but it's the rollout of the single patient record, which came from the NHS 10-year health and care plan. And that's because it's starting within maternity services, which could significantly improve interoperability across community, clinic and acute settings. It's something we've been trying to do since the day of dawn. We're not any further on. I'm hoping it will help teams identify risks earlier. We can escalate more effectively. We can just communicate communicate more effectively, and it will help us deliver safer, more joined up care overall. Alongside this, in London, we're also exploring ambient voice technology. So AI is going to get really big really fast. We're exploring this both in community and clinic settings, and the main outcome of this is to reduce documentation burden and support early risk detection. So I think together these innovations could transform how we deliver safe, responsive care moving forward. I'm quite excited by it. Fingers crossed.
Excellent. Thank you, Victoria. And Ruth, can I come to you, please, for an example? Could you share an example of a clinical safety review that has directly improved patient care?
So I'm just thinking about, we've just recently reviewed our Isla safety case file and the hazards within that. And one of the areas that we wanted to be able to improve was if a member of staff has already edited something that's been submitted by a patient, how does another member of staff know that that's been edited, it's been reviewed, and that they don't then go in, review it again and make a decision that's already been sort of, if you like, had a decision made on it. So part of that development work is that we can see when edits have been made, by who, when, and what the edit was. So that will all help with our ability to be able to see where we are with that particular patient, what's been submitted, who's dealt with it, and give a much clearer picture to anyone who picks up that record.
Perfect. Thank you, Ruth. And I'm conscious of time, so could we move on to one key takeaway? So if I could ask each of you, if there's one thing that you'd like the audience to go away with today, one key takeaway, what would that be? Karina, could I start with you, please, for what is your key takeaway for the audience?
I think it's important in terms of ensuring clinical safety. I think it's important that clinical safety, and as Victoria said, works hand in hand with patient safety, because they quite often seem to diverge, but we need to bring them back together. But I think it's really important that whilst we do clinical safety properly and thoroughly, I am keen that it doesn't block innovation. So I think it's about making sure you've got the right processes in place so that you can do it efficiently, and that it doesn't delay innovation.
Excellent. Thank you, Karina. Victoria, what is your one key takeaway?
I'm stealing my comment off my slide. So digital is not the solution. It should be the enabler, which will allow us of more safer, patient-centered care.
Nicely put. Ruth, can I come to you for your key takeaway, please?
Yeah, don't be frightened by things. Just ask lots of questions. I think until you're satisfied, keep asking questions. That's the key. And when you're satisfied, then you know you've got the right thing there.
Excellent. Thank you. And finally, Pete, what is your one key takeaway?
Very much agree with everything that's been said. I think my key takeaway would probably be to keep a very strong sense of perspective on risks, and make sure that if we're setting out to solve something that is a known risk and a big significant one, then let's make sure that we don't get too waylaid or delayed by a risk which might be a very, very small one relative to that larger thing. So it's just to keep and that's in no way to diminish, the importance of very thorough clinical safety reviews, but we just need to make sure that we keep all of the improvements very much sort of in priority order, I suppose, so we can move forward as fast as possible.
Excellent. Thank you. And that's a really nice way to close the webinar. Some great takeaways there. So thank you for those. I'm conscious of time. We're almost at 1 o'clock. So it's been a great webinar today. I'd like to thank the panel for joining us. I think it's been really practical. Thank you for sharing your experiences and learnings, which is a key objective for the webinar, really. So we appreciate you taking the time out of your busy days to join and share your learnings with the audience. And thank you to the audience as well for joining today and asking any questions. I think it's been a great webinar. So if you'd like to read it back, it'll be available in the next day or two to read back, and the recording will be shared with everybody so you can watch it back too. And feel free to share it with your colleagues as well. So it's just turned 1 o'clock, so I'll have to close the webinar here. Thank you again to the panel, a super webinar today, so we really appreciate it. And thanks to everybody for joining. We hope to see you on the next webinar. So thanks, everybody. Have a nice day. Take care.
Thanks very much.
Thanks.
Thanks.
Bye.
Cheers. Bye.